The production of this program is made possible thanks to the support of the following and viewers like you. Why do some healthy children succumb to overwhelming bacterial infection while others survive or not become infected at all? Asked Dr. Stuart Turvey of BC Children's Hospital and UBC's Faculty of Medicine. Why do some children suffer crippling juvenile arthritis or life-threatening asthma? For the past 16 years, Turvey and a team of researchers have been asking and answering these questions through the National CHILD Birth Cohort study, starting with a population of children with a defined infectious or inflammatory disease phenotype. Turvey says the knowledge generated by this approach will aid in diagnosis and highlight mechanisms for disease pathogenesis and ultimately identify novel treatments. I invited Dr. Stuart Turvey of BC Children's Hospital and UBC's Faculty of Medicine to join me for a conversation that matters about the benefits his research are delivering to children's health. Dr. Turvey, welcome.
Hello, good morning.
I'm fascinated by the work that you've done from a couple of perspectives. One, you've got this living cohort that you've been able to follow. Why was it important that you follow them rather than go back and investigate retroactively?
Yeah, I mean, we call this in the trade a birth cohort. The idea that we start for this study in pregnancy and have followed families. That matters because we're not asking people to go back and remember what happened maybe during pregnancy or those first few months of life to try and link it to disease. We know really from the beginning, so it works out as a very powerful research strategy.
So what was the origin or the genesis of this, and how did you pull it together?
Yeah, that's a nice question. So it's not me. So this is really teamwork across Canada. And so we came together recognizing that there'd been an epidemic of asthma and allergies. So through from the 80s through to early 2000s, the rates of asthma and allergic disease had tripled. And, you know, if we think about that, I went to school and there was no kids allergic to peanuts, for example. And then I had a daughter and she was in school and there was all these children allergic to peanuts. And so something had happened in our environment. And so we got together a large group of Canadians to start this birth cohort to really start to understand the origins of childhood diseases, including the origins of asthma and allergy.
So how many did you sign up?
3,500 generous pregnant women signed up across 4 sites in Canada for this. And they've stuck with us by and large. So the kudos for this goes to these generous families.
So they're early on in pregnancy and they say, okay, I'm willing to be a petri dish.
A partner, I think, is how we see it.
I'm being a little flippant there, but in essence, you're saying, okay, we're going to monitor and watch what happens with your body, the way that you deliver your child, your life, the food you eat, what animals you have in the house, and so on. What did you start to discover? Let's start with asthma, because you talked about asthma, but then we can look at other.
And so it was almost by chance when we started this, designing this study back in the early 2000s, there'd been growing understanding about the importance of what we call the microbiome. So these are the bacteria that live in our bodies, and the most enriched site for those bacteria is in our intestine and in the stool. And we figured that families wouldn't mind giving us a dirty diaper. And so almost by chance, we started collecting these dirty diapers from kids at when they were 3 months of age, at 1 year, and we followed them on. And what's been incredibly powerful with new genomic and sequencing technology is that we've been able to then define the community of bacteria that were in those diapers, in those poop samples, and show, in fact, that the children who went on to develop asthma and other allergies were actually missing important health-promoting bacteria in the first year of life. So that's the crux of the finding.
The production of this program is made possible thanks to the support of the following and viewers like you. So you talk about using genomic tools.
Yes.
Were those tools able to then help you identify just what it was that they were missing? And is it common across all children, because we all have a slightly different genome?
Yeah. Mm-hmm.
And if you were able to identify it, what is it?
Yeah, so what we're seeing, I think if we just sort of take a step back, I think children in Canada today and other developed countries are growing up in a different way than we as humans evolved. So where we have smaller family sizes, we're not living with animals or on a farm, we're breastfeeding less, we're being delivered by cesarean section, we're having antibiotics. And when you think about all of that, what it really adds up to is less exposure to these health-promoting bacteria.
As you're saying that, I'm realizing, and also most of us live in pretty ultra clean environments now. We use some pretty harsh cleaning products to get rid of those germs that we go, no, that's bad. But you're saying, no, we actually need those germs.
Yeah, and when I went to medical school, I was taught bacteriology was to name these scary bacteria, and I was told which antibiotic would kill them. We were taught to be scared of these. I think we need to reframe that and realize that the vast majority of microorganisms, including bacteria, are actually important for our health. And what's happened over the last decades with industrialization is we've been losing that bacterial biodiversity, and that matters. We worry about losing, for example, polar bears or pandas. We also should worry about losing health-promoting bacteria.
So what's the connection directly from a loss of microbiome germs and asthma?
Sure.
And what do you do to say, okay, we see this in your child, here's how you can start to address this?
Yeah, it's a nice question, right? I'm talking about what we're seeing in the gut, and we're thinking of asthma as a disease, a breathing disease of the lungs. The link there is actually the immune system. And so what we know now is that we normally have a rich array of bacteria, and they actually help train the child's immune system early in life, the metabolites and other exposures from those bacteria. And so children who are missing bacteria, or in experimental models where the bacteria are taken away, the immune system becomes confused, and that exacerbates the asthma. And so now we're recognizing a small repertoire of bacteria that are at lower levels in those kids who are going on to get asthma. You asked the question, what can families do? Yeah, what can we do? So I think there's a lot of things we can do. And some of them are simple and some of them are more complex. The simple things are really to cherish bacteria. And so what I mean by that is...
It sounds counterintuitive.
Yeah, what I mean by that is let's use antibiotics when we really need them. So let's minimize prescription of unnecessary antibiotics. And there's been a big movement towards that. That will reduce the rate of asthma. We've shown that.
Because you found that link between antibiotic use and asthma.
Yeah.
It's remarkable, isn't it?
Yeah, children who take more than one or more courses of antibiotics in the first year of life have about double the chance of being diagnosed with asthma at age 5. Wow. So that really matters. The other superfood for protecting the microbiome and promoting health is breast milk. And so we as society should be doing everything we can to promote successful breastfeeding. And we've identified some species of bacteria, including Bifidobacterium infantis is the name, which is promoted by breastfeeding and is really important as being protective against asthma.
The production of this program is made possible thanks to the support of the following and viewers like you. I noticed when I was looking at the work that it was like, it's actually breastfeeding. Like, don't pump the milk and say, okay, I'll give it to the child later. Yeah. No, it actually is mother-to-child contact.
Yes, I think, but it's not exclusively that. And really, I think the message is if there can be exposure, enhanced exposure to breast milk. And sure, there may be some benefits from skin-to-skin breastfeeding, but that doesn't diminish the benefits of for example, pumping. So,
right, mom being the source.
Yeah, and I, as a male, I always feel a little uncomfortable about this, but I think talking about this, but ultimately we, as society, have a responsibility to make breastfeeding more accessible and more successful for as many infants and their parents as possible. That's the way I see it.
I agree, but what was also interesting is I was looking at what the health consequences to a child are based on the method of delivery, natural or cesarean.
Yep.
What's the benefit of going down the birth canal?
We think one of the obvious benefits is the microbiome, and so cesarean section is an incision and a sterile delivery in an operating room versus transit through the birth canal where you're exposed to, and it's really the first big exposure to bacteria, and that's important. So again, a message would be cesarean section can be life-saving for the child and the mother, but again, let's be thoughtful about that and use that when it's
absolutely
really
necessary. Yeah. I also found it interesting that when you talk about having a pet in the house and how important that is, and the link between that and obesity.
Yeah. No. So a very senior doctor who really was our founding director of child study. His name's Malcolm Sears. He's now retired, but he said that maybe the advice should be that as families leave the hospital with the baby, they go home and get a dog, and that will protect against asthma and allergies. But it's really, the dog example's one example. I think it's about being exposed to the natural environment and allowing families and to be encouraged to be out there, not to be so paranoid that if the child interacts with things. In fact, this is how we as a species evolved, and so bringing back these safe, appropriate contacts is a good thing.
I couldn't help but notice also you talk about the relationship between ultra-processed foods and the impact on the microbiome, asthma, and relationship to a variety of other potential ailments.
Yes.
This really is a message that is being delivered frequently now. Ultra-processed foods.
Yeah, and I think these messages are sort of what a sensible grandmother would tell you to do. Eat wholesome, healthy, less processed foods, encourage breastfeeding, let the children play outside. These are the messages because those exposures have many benefits, but including helping us be exposed to these health-promoting bacteria.
The production of this program is made possible thanks to the support of the following and viewers like you. So you've been doing all of this work. How has it informed you in your treatment of your patients that come in to see you in BC Children's Hospital, coupled with advances in genomics that allow you now to be able to say, okay, I can look at this child who wasn't part of the cohort, but I'm informed in a way now that helps me to deliver better treatments.
Yeah, absolutely. So I think we've worked hard to mobilize these research discoveries to better health for families in BC and beyond. And one very practical example of that is around messages for antibiotic stewardship. When we think about being careful with antibiotics, often the message is, let's not use too many antibiotics because the bacteria might become resistant. That's a society level problem, but less an individual choice, I would say. And so it's been really helpful to expand the messaging around antibiotic stewardship to include, less antibiotic exposure can also protect your child against things like asthma. So that's been hugely informative, to be frank. We talked about genomics and sort of, I think, disruption of the way we practice medicine through genomics. And here we've talked about sequencing the bacteria and so on. That same rapidly advancing sequencing technology has allowed us to look at the genetic makeup of children in a very detailed way. And so now we can use that knowledge to diagnose children who are suffering with rare and perhaps brand new human diseases.
Can you give me an example?
Sure. Yeah, plenty. And it may seem sort of unbelievable, but I would suggest that every day at a children's hospital, like BC Children's Hospital, there'll be children in the hospital who have a disease that has not yet been described, a brand new human disease. And the reason I say that with some confidence is that we as humans have about 20,000 genes in our genome. But the global knowledge has only linked 5,000 of those genes to a human disease. And we have many examples of that.
We're only at that point.
Yeah. So the discovery space, we're only 1/4 of the way there. And so we have had, I think, remarkable success partnering with our clinical colleagues, looking and working up children who have a disease that the doctors scratch their head and say, this is just different to what I've seen in my experience. And we've diagnosed close to 10, I would say, new immune system disorders that hadn't been recognized over the last 5 years or so.
Wow. Okay, and so that process starts by you taking a genetic sample from the child.
Yeah.
And then running it through sequencing.
Yes.
And then you have to do the work of identifying what is and isn't working here within that child's. And so then what do you do with that information? And the reason I ask it is, for the longest time, I believed that we're not very far away from having bespoke medicine. I'll be able to go in with my genome sequence to the doctor, but I quickly learned that if you take that into the doctor, most of them would go, well, I don't know what you want me to do with this because I don't know how to read it.
Yes.
So what do you do with it when you've got that information that can lead to a better health outcome?
Yeah, and that's sort of a multi-pronged discussion, but what's really disrupted our clinical practice in this last 20 years has been the cost of sequencing. So I started at BC Children's Hospital in 2004. And at that time, to sequence the human genome was tens of millions of dollars.
Yeah.
And so it was inaccessible. We didn't do it. Fast forward to today, sequencing a human genome is less than $1,000.
Yeah.
And you talked about the fact that doctors don't understand this. This just reflects that this really wasn't part of the medical curriculum when I went to school, but now is a big part. So it's profoundly disrupted what we can do, and we are able to do the sequencing, and then we use computer algorithms and artificial intelligence essentially to sift through that genomic information and see what's common and reflected in population databases, and then what's left that might be disease causing. And so we filter that down to a small number or sometimes just one genetic change.
And so now how do you then address that? Are you then saying, okay, well, we're going to come in and we're going to help your body modify genetically? Or do we say, no, this is what you're going to need as far as treatment is concerned?
Yeah. So there's probably one step before that, which is we find a new genetic change and we think, wow, this might be the cause of the disease, but this has never been described before. And so the nice thing at BC Children's Hospital is we have a fantastic research institute. And so I have a research lab where we can go and in cells from the patients and model systems prove that this genetic change is the cause of the child's disease. And then the question is what's next? And that depends, I think, on the nature of the genetic change. So for some, there might be a medicine that turns on or off the way that gene functions. And we've done that successfully several times. We call that drug repurposing. Take a medicine that's approved and we're able to treat the child.
So how do you know that that drug is going to interact with that genomic anomaly the way that it does? Is that more genomic research that gives you the information that you can say, we believe that this will work?
Yeah, I mean, the genes are really sort of a recipe book for making the proteins and the machinery of the cells. And genetic changes might cause that machinery to work too well, to be working overtime, or not to work well. And so typically if the machine's kind of working overtime, we can use approved inhibitors like for other medicines to turn that down. And in our immunology space, some of the medicines developed for cancer that turn off cancer pathways will also turn off these immune pathways in a very effective way.
What are alternatives to using a drug? Is there something else that genomics brings to the equation that you say, well, we can actually go in there and help your body?
Exactly. I think there's two other options, and I'll now sort of talk as an immunologist more because that's my expertise. One would be we can do what we call a bone marrow transplant or hematopoietic stem cell transplant. We could give the child a whole new transplant by a whole new immune system by replacing their immune system from a donor. That's just wholesale replacement of the immune system. And the future, the cusp where we are now, I think is what you're alluding to, which is genetic engineering.
Yeah.
Can we rewrite the genome to correct that spelling mistake? And that was science fiction until 5 years ago, but is reality now. And in fact, one of our patients who had a rare immune system disorder recently was the first person in the world to receive something called prime editing, where they rewrote his genome in cells and then put those cells back into his body, and his immune system disorder was cured.
And that's here.
That's a global partnership. So this one, the patient actually had to travel out of the province to where the clinical trial was done. And he was one of 2 people in the world who received this treatment, and it was just published about a month ago in the New England Journal of Medicine.
Well, this has been the promise of having mapped the human genome some 25 plus years ago. It's taken a while to get to this point, but in essence, you're saying we can deliver a bespoke remedy.
We can. I think the challenges of that is, while we can do it from a sort of practical perspective, these 2 patients, including the one that we looked after, proved that. The question is, how now do we do that in a healthcare system that ultimately is constrained, and how do we make those decisions?
That's an entirely different conversation, but you're right. How do we take it from the lab and take it to scale?
Yeah.
Thank you. I mean, this is really exciting, and it's the kind of advances that I've been hoping for a long time, because I've just been so keen to see what having mapped the human genome can deliver.
Yes.
And it's starting here with children in British Columbia. We're playing an important role. Thank you very much.
Thank you.